Good evening. I'm Kimberlé Crenshaw, Executive Director of the African American Policy Forum. Together with the Center for Intersectionality and Social Policy Studies, we welcome you to the first event of our annual series, Her Dream Deferred, a week on the status of Black women. For the past 6 years, in honor of Women's History Month and the UN's International Decade for the People of African Descent, AAPF has convened Her Dream Deferred, always in the last week of March, in order to amplify the voices and stories of Black women and girls. The series serves to disrupt dominant and stereotypical narratives around Black women and our well-being. We aim not only to speak to the harms that Black women and girls face, but also to hone the tools that are necessary to dismantle all of the structural barriers that plague Black women in our homes, our schools, and in our communities. Since the very first Her Dream Deferred back in 2015, when we hosted a panel called Are Racism and Patriarchy Making Us Sick? Black Women, Societal Inequalities, and Health Disparities. We've been convening programming on the myriad ways Black women's experiences throughout the healthcare system reveal multiple sites of intersectional vulnerability. These sites of intersectional vulnerability tell us that absent urgent treatment, they will continue to leave Black women with disparately negative health outcomes. The past year has been marked by the epoch-defining twin pandemics of COVID-19 on one hand and recalcitrant police violence on the other. These ongoing crises reflect vulnerabilities that are historically structured and politically reinforced, ranging from the gaping disparities in infection and death from COVID to the horrific consequences of racialized policing and punishment, all that were manifest in the killings of George Floyd and Breonna Taylor. The intersectional vulnerabilities of Black women in healthcare were made tragically clear last year in the death of Dr. Susan Moore in December. Dr. Moore was one of the small number of Black women working as a licensed physician in the United States, a profession where she had an increased exposure to contracting the coronavirus. After being admitted into the Indiana University Hospital system with COVID symptoms, Dr. Moore's condition worsened quickly. But even as her symptoms grew more severe, her pleas for care were ignored. She was told to go home as her breathing became more labored and as further complications from COVID-19 developed. Soon thereafter, Susan Moore died. Dr. Moore's tragic death is a familiar, horrifying tale for Black women. It illustrates that class, education, wealth, geographic location, even being a doctor, cannot insulate Black women from the rampant misogynoir prevalent in healthcare. Indeed, research shows that in the short term and the long term, Black women are more likely to experience consequential impacts from COVID-19. But that disproportionate impact is no surprise when we know that Black women are also 3 to 4 times more likely than white women to die during childbirth. Moreover, Black women experience what's called weathering, a term originally articulated by Arlene Geronimus, a process by which our bodies age faster than white women's due to chronic stress linked to social determinants of health. All of this undoubtedly has impacts not only on the physical health of Black women, but also bears on another silent crisis facing Black women, their compromised mental and emotional well-being. These conditions constitute the hallmark of Black women's erasure. We're subject to disproportionate injustice from a range of overlapping institutions, healthcare being one of the most significant among them. And yet in the face of that injustice, we get relatively little structural, institutional, and even interpersonal support. So what would it take to address and deconstruct misogynoir, a term coined by Moya Bailey and Trudy in the healthcare industry? What pictures can we paint of the current ways that the industry apprehends Black women? And how are these pictures related to the past? What purchase does the frame of the medical industrial complex add to all of the experiences of Black women confronting misogynoir in seeking the most basic of rights, the right to survive? We know that when it comes to another pandemic we faced last year, that of police violence, that we have to begin by understanding that racism is fundamental and constitutive of the entire enterprise. What do we need to catalyze that same understanding in healthcare? Well, my sisters today tell us that to move forward, we have to understand that healthcare is not apart from these structured systems. It's actually central to them. The moment then calls for tools that identify the structural and institutional dimensions of racial power and tell us what we need to do to disrupt them. This conversation, this moment is designed to bear witness, to activate you, our listeners, with the tools you need to be both advocates for yourselves and more broadly, to be advocates for our community and for our collective well-being. So I'm pleased to be joined by some of the leading champions for equitable healthcare treatment of Black women. Dr. Alisha Liggett is a board-certified family medicine doctor with a clinical practice based in New York City. She has worked in clinics caring for medically disenfranchised clients all over New York City and has authored several articles, trained dozens of healthcare practitioners, and taught health education seminars in her community. Dr. Karen Scott is an epidemiologist, educator, and obstetric hospitalist with more than 20 years of experience supporting persons across the sexual and reproductive life course in high-need, low-resource communities. Dr. Joia Crear-Perry is a founder and president of the National Birth Equity Collaborative. I should say the founder. She's a thought leader around racism as a root cause of health inequities, a speaker, a trainer, an advocate, a policy expert, and a fighter for justice. And last but not least, Dr. Gail Wyatt, my colleague at UCLA. She's a clinical psychologist and board-certified sex therapist known for her research on consensual and abusive sexual relationships and their influence on the psychological well-being of people. She is a professor of psychiatry and biobehavioral sciences at the Ronald Reagan UCLA Medical Center and author of the book, Stolen Women, Reclaiming Our Sexuality, Taking Back Our Lives. Thank you all so much for joining us. I really can't overstate how important it is to sit down with a group of women like all of you at a critical time like this. So welcome. So before beginning our panel, I'm going to play part of that video I mentioned that Dr. Susan Moore recorded while she was bedridden with COVID just weeks before her untimely death. For those Black women on the call today, her desperate pleas for fair treatment resonates deeply, and her words are a call that desperately needs to be heeded by the entire medical community. So let's listen to her.
He further stated, "You should just go home right now." And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting. So, spoke to patient advocate who left me wanting. There's not much I can do. So I started asking, send me to another hospital where they can treat me. And if they're not going to treat me here properly, send me to another hospital. Well, next thing I know, I'm getting a stat CT of my neck with and without contrast. The CT went down a little bit into my lungs, and you could see new pulmonary infiltrates, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward and I maintain, if I was white, I wouldn't have to go through that.
So here we have it. Despite her pleas for assistance, she wasn't seen as a credible source of information about what was going on in her own body. Seems not to have been treated with an iota of compassion or empathy. I mean, there's so much here. I want to just get your initial reactions to this heartbreaking video. Karen, what do you see here?
Thank you. It reminded me of when I went to the emergency room last year twice, because I also am a COVID long hauler, and the second time I went, still not getting the pain medication that I needed, and even having to having my own COVID doulas who were midwives, who I had to like bring in, one local one from around, one in Ohio, just for someone else to advocate for me as a Black woman physician in the same city where I went to get care, seek care, and they don't. I realize how much the world hates Black women. I mean, that's honestly how I felt, and how much we are discarded and disregarded, and seen as subhuman. So much so that the lack of responsiveness to our incredible pain that occurs with COVID, you have to perform. And I did the same thing. I asked the nurse, I said, I'm not seeking drugs. I'm in such pain. I can't even be my most optimal self. But I have to tell you first, I'm not a drug seeker for you to give me pain. That was humiliating. So I feel that in my spirit, and it's crushing.
Yeah. And it, you know, it doesn't matter who you are. It doesn't matter where you come from. The need to perform, to perform outside of the known script that they see you in, even when you are in your most desperate circumstance. It is also part of the burden. It's part of the production of Misogynoir. Gail, what do you see in it? What resonated for you?
First of all, it was devastating to see and to hear her in such pain that she could barely speak, and to still have to prove that she is not a part of three assumptions that I heard. One is that she was a drug addict. This is a woman with a problem, an illegal problem, not something legitimate. Second, that Black women are impervious to pain, that we can endure pain beyond the human, almost like the John Henry syndrome, if you know the old fable.
Right.
And it's relevant to men and to women, that we can take more than most. And third, though she didn't display the anger, I am almost sure that her perseverance was interpreted as angry. And you know, the angry Black woman is one that's so well known, and also that intimidates men and women in the larger healthcare system, almost any system. People expect us to be angry, to be tough, and to have some kind of illegal problem that's always outside of the law.
Yeah.
And I think that what she was having to prove was that she was none of those, almost by demonstrating through her dying body that she really needed help.
Yeah. And Gail, you pointed out the interpretation of Black women when we're advocating for ourselves as being angry, apparently a response to the outcry about this generated a letter on the part of someone in that healthcare system, basically saying that she was threatening and intimidating to the medical staff. This is a woman who is dying.
Yes.
And her impending death, absent meaningful intervention, is not enough to remove the specter, the threat, the idea that this is a dangerous Black body. And the fact that even women are not immune from being interpreted as being dangerous, even when they are completely incapacitated, is such a dramatic illustration of how our bodies scream threat even when our bodies are dying. It's just so, it almost leaves you speechless. One would think that after they didn't care for her in the way they should have, and it became clear how sick she was, the mea culpa would be the only thing that letter would say.
Exactly.
And instead, the effort to justify is just beyond words. Alisha, I want to come to you just to get your sense of what you saw in that.
Yeah, I mean, I feel like you could just feel the gravity of her experience, what she was going through. You could hear the desperation in her voice, the fact that she couldn't even really speak in full sentences, as everyone had said, who spoke previously, that this was a dying woman who was just basically crying out for help. And the fact that, the numerous people that care for individuals in the hospital, there wasn't not a single person who could advocate for this dying patient. There's not a single individual there who could, speak and advocate on her behalf that maybe the plan of care should have been changed or modified to accommodate her. Not anyone who could provide an alternative perspective around this narrative that they were creating about her, this false narrative about her being drug seeking and about her, fabricating her pain. That just makes me sad that with the thousands of people that work in a hospital, and I'm sure the dozens of people that were on her care team, that there wasn't a single person who could speak to any of those things. And she just died senselessly, And also, just hearing her, it just reminds me this could be my mother or my sister or my friend or a colleague. It could be me, I was also that person who was afraid to die when I was birthing my son, and that fear that you feel, and also that sense that you need to silence yourself, that you need to make yourself smaller, even though you're someone who traditionally has a lot of power and is used to using your voice, that you need to quiet yourself, that you need to justify how you're feeling and your experience in your own body, that it can't just be taken for face value, that you have to somehow perform.
That constant burden, of performance against the stereotype, performance against the expectation, performance against the script. There is no escape. Death is basically the only escape from it. And as such a abiding condition of our lives, the fact that we're only starting to witness public discourse about it is just another layer. And Joia, I want to come to you because you co-wrote a piece in the Washington Post about Dr. Moore's ordeal. And I was really struck by so much of it, but one, to say that if a physician can't be heard by her own peers to save her life, then who will listen? Who will be held accountable? One of the searing questions that your op-ed raised. So what was it that was so important to lift up, and what do you hope will be the future that is grounded in this tragedy? If we don't want Dr. Susan Moore's death to be in vain, what has to happen? What message needs to be heard, and what has to happen?
Well, I think people are familiar now because of the murder of George Floyd, of seeing actual police violence, right? Of like watching a policeman murder someone. We used to hear about it, but we had mass protests after people sat at home and watched his murder and saw racism with their own eyes. Because all of us knew when we're watching Dr. Susan Moore, we know it's going to happen. It's a tragedy that we already know and can feel. She feels so familiar to me, that her cadence, her voice, the way she's explaining things. She could be one of my friends, she could be us, she could be, so I felt so familiar, but I also felt like I was watching a slow tragedy, right? Like watching a morality play. That's what it felt like watching George Floyd as well, the murder of George Floyd. And that's what it feels like when I watch Dr. Susan Moore. So I'm hoping people can see the tie between the way that racism is in the prison industrial complex and mass incarceration and police violence, and deeply embedded in our healthcare system. That here is a woman who knew who to ask for. She knew as a physician, she knew the right words to use. She probably made a debate with herself about if she should even tell them any of this stuff, right? She probably started with, maybe I just won't even tell them I'm a doctor. I'm just gonna see what happens. Then they started cutting up. So then she started trying to use her big fancy words that she knew. And I will say this, we know that people blow you off with a CAT scan. That's the doctor way of saying, ain't nothing wrong with you, because you can't really find pain with a CAT scan. So it's like it's a way, and then he did this to blow her off, and it showed actual things that were wrong with her, right? And so then he had to treat her pain. He had to accommodate. He still didn't treat her what was killing her, right? He still didn't do the other things that she was asking. So it's still this opportunity for us to watch a healthcare system live, watch a person who should still be here, no longer here. Hear her words, hear her say, she maintains, were she not a Black woman, she would still be here. And that's a fact that we should all embrace and then do something differently about.
Mm-hmm. And so much of the commentary, and as I mentioned earlier, your point of inquiry was nobody is credible in this body, right, in this system. The fact that she was a Black woman trumped everything. So those who frame the disparate outcomes that we face in terms of lack of knowledge, in terms of how to navigate, lack of access, to good healthcare. All of these are ways of denying what it is that we saw Susan Moore having to deal with, right? The fact that she was a doctor made no difference whatsoever. So I'm wondering for all of you, what ways your own personal encounter with the medical establishment shapes what you eventually were able to see more clearly and to dedicate your professional lives to addressing. And so Joia, since you have the floor, I'm going to ask you first, when you think back in your encounters as a Black woman in the healthcare system, what were your earliest observations that made you know this is going to be different for me than it would be for a similarly situated white woman, and I am going to have to navigate this fact?
And I think even before I had the words and the language around racism, I knew that I was treated differently based upon my skin color. Like I was clear, and even if it's not something that all of our parents tell us you have to be twice as smart, do all those things, but it was just something innately I knew, even in healthcare. So when I became pregnant as a college student, I knew I needed to navigate that system with help, with support. I could not just show up as a 21-year-old pregnant person to any old doctor. I had to go to someone who my mother knew and picked, at a place that people knew Miss Carolyn. She was the pharmacist at the hospital, so she could help try to protect me, because if I just went there by myself, all kinds of things could happen. And I knew that without even understanding misogynoir, without understanding racism, just knowing I needed the protection and the favor of someone who has given her time and energy in this space. And so they valued my mother because of her work. Her labor allowed them to see me as more human, right? They love Miss Carolyn. She's a good pharmacist at this hospital. Okay, well, love on her daughter like you love on me, right? And so that entree into receiving care, into knowing that my peers and my colleagues, I had two friends, one who had a fetal demise while we were in college and was told to go home and wait for the baby to come on its own, was not given any other options. I knew, even though I didn't know enough about medicine, I knew there had to be other options, right? Like they just give you one choice. And then another friend who had to have a baby an hour away from where we lived because no other places would see her. So all these early interactions with the healthcare system that devalue Black women, I knew when I got pregnant at 21, I had to have protective factors to help ensure that I was able to survive my pregnancy. And so I wanted to become a physician to help mitigate, like the system shouldn't make it so hard that you have to plan for how you're gonna navigate it just to have a baby.
And that's so revealing that your desire to become a physician was influenced in part by how you knew you had to navigate as a Black woman. But then you find out, we'll come back around to this, of course, but you found out that not so simple in terms of going in and doing the right thing, right?
Exactly. The system is built to create the things that it does.
Exactly. And there's so many ways that we can think of these conversations in parallel because, I go to law school thinking, okay, we need to have more lawyers because the law is really jacked up in the way that it treats Black people. And then you get there and it slowly dawns on you, okay, this isn't a defect.
Right.
This is kind of built this way, right? So then the project is bigger than just being a better doctor.
Right.
You basically have to be about deconstructing the thing that you're trying to be a part of, which all of you in various ways have been about. So Alisha, I know you have written powerfully about your own experience of being, as you said, reduced to a Black birthing body. So can you explain what your experience was and what you meant by that reduction?
Yeah, so as somebody who was born and raised in Seattle, Washington, and who was really kind of educated in mostly white spaces, it wasn't really until after I had my son and I had actually started hearing the experiences of my patients and in a way reliving my trauma through my patients' stories that it actually dawned on me that something was not right here. So even, years into my career, even despite feeling like having had, experiences in healthcare personally where I just didn't feel well after I had left the doctor's office. I felt like I had been devalued, but I couldn't really quite identify or have the terminology to really pinpoint what it was that I felt or what I experienced. Why it was that the doctor wouldn't look at me or wouldn't acknowledge my story when I'm trying to explain to her what I'm experiencing in my body, or even when I'm like crying out in pain during a gynecological procedure that, the doctor just gets up and leaves the room. No acknowledgement on a human level that somebody is suffering and that you're perhaps inflicting pain on someone's body, right? So it wasn't until I had started to hear these stories again and again and again from my patients, women of color, that I realized that there's a silent epidemic here. This isn't something that just I experienced. It's not a one-off, and then I kind of started probing more, family, friends, colleagues. Everybody has a story. So I really felt like for me, it was important to tell my story, mostly because in my family and in my community, I feel as though silence is golden. It's important for people to keep their stories, particularly as it relates to vulnerability, to themselves, to keep, especially as it relates to health, keep those things hidden and suppressed and not speak about those things, not speak about weakness, especially if you're a Black woman, to kind of be perceived as being weak is something that was not seen as favorable in my family. So I felt like, it's time for me to speak out about my experience and write about it. And when I did that, the response was overwhelming in terms of the number of people who they themselves told me, I didn't even realize that my experience was terrible. I knew it was bad, but I couldn't identify or commiserate with other women who'd been through something similar when they also had birthed their children.
Mm-hmm.
And these are professional women, these are educated women, these are people who you would expect would be able to identify, like myself, identify racism when you're confronted with it. But racism has a different face in healthcare. And I think that's why it's so difficult for people to identify. And that's the reason I feel like it's so important for us to share our stories, to share our narratives, because we can use that as an opportunity to uplift one another, to support one another, and also to be impactful in terms of how we move through healthcare for future generations.
Yeah.
So it was just super important that I shared that.
And we will direct people to the piece. When you look back on it, there's a snapshot of you on the table that you described. Share just a little bit of what that snapshot is that allows people to see through your eyes how you were being treated.
Yeah, there's several instances. I think it started with my birth experience in terms of me really realizing that there was a problem. Issues with pain, which I expressed during my delivery because my epidural was not adequate. Also, sorry.
You can start that over. You can start.
Okay, I'll start again. So it wasn't until I actually birthed my son that I realized that, even over the course of my life, there were several instances where I had experienced healthcare mediated trauma at the hands of racism. When I was a college student, I recall having this procedure, as I mentioned, and the doctor just took no care with my body whatsoever. She was so rough and aggressive, and I just didn't understand, as a young 20-year-old, what I had done to kind of deserve this kind of treatment. I wasn't angry. I made myself as small as I could. I followed all of her instructions. So to me, it wasn't clear what I had done. And I left there so dejected, and it just made me feel like I never want to go to doctors ever again. Like, these are like the worst people on earth, like barbarians, that they can just take so little care with people's bodies.
Mm-hmm.
And even in my pregnancy, as a physician myself, seeing my physician, her colleague, who wasn't aware that I was a physician, and her exam, again, like, she literally just left me exposed on the table with my legs literally in the air, facing the door. 8 months pregnant, I could barely get up off the table after the exam. No explanation as to what she had found or the conclusions that she had come to after her examination. And she just left the room. She's like, okay. And I was like, and I was alone. I was so confused. Like, did I do something? Does my breath smell? I don't really know. Like, I just wasn't really sure what had happened there, and didn't even feel the courage to address it with her. But just her bedside manner was terrible. And I wasn't sure is it just her? Is it me? Is it racism? I'm still trying to figure out what it is here.
And I'm sure that is also a question that a lot of our listeners are grappling with. Like, how do I read it? How do I see the role that my race might be playing inside a profession that hasn't been known to be necessarily supportive of the best practices for women. So in some ways, this is a matter of unpacking some of the historical ways that Black women have been treated in the medical profession broadly, but within gynecology in particular.
Yes.
So one of the historical dimensions of this is, of course, that it's not new. All of you have had an experience. Gail, I want to come to you as to reflect upon the old days as you and I experienced things, where some of this stuff that we're hearing now in like this post-segregated, hospital system is perhaps disappointing, but it's not unfamiliar.
Not unfamiliar. It's part of the history of most of the organizations we find now so progressive. But I have a history. And being 21 and pregnant for the first time in a very young marriage, went to the hospital in Nashville, Tennessee, a city that was on fire in terms of civil rights. And here I was, not really expecting to be treated like a diva, but to be treated in a humane fashion was what I had hoped for. I couldn't get into any Lamaze classes because they were not available to Black women. And then when I had the baby, I could not get into the La Leche Society, did not treat or provide any services. So no one came to my room to work with me about breastfeeding. But when it came to Lamaze, I knew there would be pain. So I taught myself how to focus so that I could do something that I could remember, even under immense pain. So I recited nursery rhymes all through my labor in order to distract myself from pain. It was the only thing I could think of at the time, knowing a little bit about psychology, that I could remember no matter what. And that really got me through. If I hadn't had that kind of creativity and determination that I was not going to yell, that there was a way to get through this, and I knew that other women would learn it, but I wouldn't, being in that situation, I was determined to do it for myself. But that really helped to propel me into my career and making sure that I understood how are women treated in the healthcare services. So in the system today, just you want to fast forward, Kim, because I know you want me to talk about mental health. I'm hoping you want me to talk about mental health. We're currently funded by two exciting private entities. One is Gilead, and they do a lot with pharmaceuticals in terms of HIV. I'm a sex therapist, so I have to get my funding through ways to look at sexuality. You can't get sexual research funded through the government and just say, I want to study human sexuality. So I have to always have something, some reason to do it. And HIV is certainly one. But the other group is Cal Wellness. That's a private foundation, state of California, funds, services, women's organizations. And we developed a women-centered intervention. In most of the HIV work, women are treated like little men, and they're labeled and criticized for the fact that they don't respond to HIV treatments and the medications. Well, that's because they're treated like men. They're asked to sit in waiting rooms that are male-oriented with magazines that have no relevance to them. There's no babysitting for their children, so many women have to bring someone or just not go to get the care that they need. But the most, I think, egregious oversight is there's no obstetrical and gynecological care for HIV positive women on site in an HIV clinic today. So if you have a penis, you're in good shape. But if you don't, then you just have to go cross town to find out what you need someplace else. And so what we did was in our intervention to network with organizations that offered all the care for HIV, STIs, and reproductive care in one place, so that when women came in, they could get all of those services. They could get tested for whatever they might have. They could make choices about their bodies gynecologically and make choices where they could actually get the things that they needed if it was free of charge or they had to pay. But the point is, we were addressing the needs of women. We had women of color as the interventionists. We had women of color teams, and the women responded fabulously. They wanted to come every week. They wanted to be a part of these groups because they felt they were relevant to their needs. And the first thing we teach women when we do work in an intervention is the history of Black women in America. That is something that most people don't know anything about, how we've been treated, how our bodies have been ignored, how our need for healthcare has been overlooked. And they just soaked it up and made changes in their knowledge, changes in their advocacy. Now they knew what they should be asking, and we taught them to negotiate with doctors about the care. This isn't anything that you grow up with. You've got to learn, and we did it, and we've got fabulous results. So I just want to let you know the depression and the trauma that they received decreased because we gave them facts, we gave them history, so they understood where they were coming from and where they needed to go.
There's so much there, Gail. First of all, the idea of culturally competent healthcare, I know strikes some people, the more traditionalists, in as being, well, that's exactly what we don't want to spend time on, because it's just the body and you don't have to have anything culturally competent, and that sort of repudiation of what people everywhere else have been thinking about and talking about by the healthcare industry is sometimes shocking to those of us who are not in it. But I also wanted to say, part of what I found so shocking in what you said is like, Jesus, not even Lamaze. Like, what is that saying about Black women and reproduction, that we can just drop babies, that, and we don't need to learn how to nurse them. It's almost like, and I want to come back around in a sec to ask you about this, Joy, but it's sort of like the plantation origins of gynecology and how Black women were situated in it is still stretching across history to even shape how Black women childbearing now is treated. And probably people don't even realize that's what they're rehearsing.
And they don't know, Kim. They don't know that those first surgeries that were done on women were done on slaves that had no anesthesia. And they had multiple surgeries. One woman had 30 surgeries without anesthetics, and finally died. But the issue is, we talk a lot about the Holocaust, and we should, but we don't talk about the kind of systemic and historical, medically unethical treatments that perfected some of the procedures that gynecologists use today. And I'm not dogging gynecologists because I'm married to one, but I'm telling you that as a profession, most of them leave their residencies right there at UCLA David Geffen School of Medicine without an acute appreciation that when a Black woman looks at an obstetrician gynecologist and she knows her history, she's got to ask herself, do you know your history? Do you know that I'm assumed to be without pain, without the ability to be raped for 401 years? That if I have a rape history and a rape situation, I'm going to be treated differently in the legal system than anybody, any other group? Do you know that I have a hard time telling you the truth about how many sexual partners I've had? Because I know it's just going to cement in you an appreciation for me as a whole. So these are all things that women have to deal with, to the point where they don't want to go.
Yes. And Joy and I were talking earlier about the fact that modern gynecology owes its understanding to the torture of Black women.
That's right.
And at the same time, we're least likely to benefit from the advances. It is such a well, I can't use the word for it, but it is part of the reason why it's important for us to think and talk about what needs to happen in the medical establishment, what needs to happen in education, how you can't treat these issues, and Black women in particular, without knowing their history and the history of the way they're imagined. So there's a way in which, and Karen, I want to come back to you on this question. We talk about the twin pandemics, and one of the things that is happening now in our thinking about police misconduct and brutality is that there's this whole understanding that it's institutional and it's structural. And there's this frame that we think about that protects the existing system by recruiting people in it to hold up its lies and its practices. So in policing, it's called the Blue Shield. And much debate is had over that. There is at least an understanding that the Blue Shield is often being used to protect the institution, make it more difficult for it to be reformed, remade. Is there an equivalent notion of the white coat that we can build out to make people aware that the same analysis that you have around policing might be applicable to healthcare.
No, definitely. I mean, I know what we say today may offend people, but I think it's very important, especially as being a Southern Black woman who's an OBGYN, like everything that Dr. Wyatt, all of you are saying, it rings so true to me because I've shared that I became the monster I never intended to be because I didn't know the history of obstetrics and gynecology when I became an OBGYN. And I actually never wanted to be one. Because I remember the screams of my sisters in the South seeing their OBGYNs. And the reason why I did pursue it was because of this relentless curiosity to understand how Black women's lives are structured, right? In family, in society, in education, in labor, in relationships, in abuse, and in violence, and add on religion, and spirituality and sexuality. And so I do think that because of the ways in which our right to pursue life, liberty, and our right to life, liberty, and the pursuit of happiness is so constrained and controlled that in order to treat Black women the way the medical industrial complex does, it happens because we do have a white coat shield. We do have that fraternity, that brotherhood, even though there are women in our field. I do think we have taken on the nuances, the notions, the narratives, the behaviors, the beliefs of our oppressors. And I speak a lot about being both the oppressed and the oppressor as a Black woman OBGYN. And I've also stated that one of the best places to go to harm Black women and never be held accountable, I believe, a police officer and a physician.
Oh.
We lack accountability. There is a code of silence. There are people who are legacy, right? There are generations of people, even Black people, I'm gonna get in trouble for this, but there are generations where this is a status symbol, but to maintain your membership, you give up a lot. And I do believe what we are seeing right now is that people are choosing, right, our deaths over their comfort, over their membership, over their privilege, over their power to continue to do what has always been done, right, to Black women's and Black people's bodies. But this cry, this lack of acknowledging the epidemic and actually doing something about it, I do believe is because the way we are surveilled as Black women in the healthcare system reminds me a lot of criminals or those who've been incarcerated, previously incarcerated, like there's a felony record. We've talked about that. I always think about the electronic health record as something that is a record that follows us because we don't have opportunity to rewrite the narrative. We don't get to confront the archetypes that are in the records. And it always amazes me that lawyers and health plans and risk and liability, all those people pull the electronic record, but you never actually talk to and then believe the experiences of what Black women say happened to them, because where do we?
What's an example of that? Because when you told me that the other day, I was struck by it, like a notation in your health record about some encounter that you had at some point can shape the future of your healthcare.
Well, right. So thank you for asking. So let's think about language, right? Difficult, challenging, agitated, aggressive, non-compliant, angry. I mean, this is the type of non-medical, but now medicalized, racialized language that gets used to characterize when we assert ourselves and we want to say no. We have the right for informed refusal. We have the right to demand more information. We actually have the right to also ask to fire the provider and ask for another one. But when we as Black women activate that power and potential that every patient has, it's an affront to the entire medical industrial complex, to the entire institution itself, because they never thought that we would actually use that power that every patient has, like that unalienable right that you have as a patient. But when we activate that, it is an affront to the powers that be. And I do believe the language and the record follows us as patients, so that before there is an actual person, human to human encounter, the team has a whole script, right? A whole story that they follow. And when they walk into the room, they're meeting the record. They're not meeting the human in front of them.
Yeah.
And so I think there's such parallels between what's happening in policing of Black bodies in the actual law enforcement, but also in the medical industrial complex, and the outcomes the same: premature, deaths, senseless deaths, and no one's stopping it. We can name all those entities, but they're not. And that's so troubling.
Yeah. Yeah.
Kimberly, can we talk a little bit about the plantation the
So,
plantation to now?
yes. So this is all to come back to you. So when we left off, you were headed to medical school, right? To try to be, an agent, for better healthcare access and practices for, Black women and other people. And then what do you run up against? I'd say both in, paint a picture, give us a snapshot of what's happening in medical school that's giving you a sense that, okay, it might not be the people necessarily, it's the profession, but then you get in the profession and you're like, oh yeah, and it's the people too. Right?
Yeah, the through line between J. Marion Sims being a plantation doctor and practicing on 3 Black women at least who were enslaved, 3 Black women who were enslaved, Lucy, Betson, and Narca. We have to say their names in honor that they are human beings who were experimented upon. To my medical education in the Deep South is a straight through line to me training at a medical school that the hospital had been named Confederate General Memorial Hospital about 10 years before I went there. They named it that in 1956, which was almost 100 years after the Confederacy lost. So let's be clear about what that meant, right? Yeah. So then you get into class and I take what is in every other, I don't know every other, but most other medical schools, the class is titled embryology. My class is titled Human Prenatal Development. Just be clear about why they named it that. So in the class, my Human Prenatal Development professor says, we're talking about skin, there's mongoloid skin, caucasoid skin, and negroid skin, right? So this is in the 1990s. This is not, I'm old, but I'm not that old, right?
1990. And I just want to point out that at this point, pretty much everywhere else in the discipline, we have accepted that race is socially constructed, not real, right? Yeah. So the thought that in med school, it's like a holdout.
We are relitigating what we had decided upon since we completed at least the Human Genome Project. Since our president came out and said there is only one race, the human race, yet the colonization of medicine and healthcare is so deep and so real. We were used from the beginning of Small Skulls to the plantation to Darwin saying the title of his book is Survival of the Fittest, and the Preservation of the Favored Race, right? The very core of our field is white supremacy, is patriarchy, is misogynoir. So until we actually have that conversation, getting to me then going to med school where they're still teaching that because it is part of their curriculum. It is part of what we're taught in the books. To then me going into private practice where we have this thing called peer review, right? So you're talking about the clubs. So you get hospital privileges. This is not a privilege. I earned this. This is not a country club. I got these degrees. I made this, right? So the nature of my fighting to be in a hospital where nobody else took Medicaid patients. And here I'm in this fancy hospital where I have crown molding and hardwood floors and marble in the rooms. And the provider who I'm sharing space is an older Jewish man, and I have one hallway in his fancy big office. So the CEO wants me because other doctors at the hospital are taking Medicaid. I didn't know I was supposed to be racist and classist and all the other things to work at this hospital, even though my daddy said, now they don't let colored doctors work there. I was like, no, it's across the street. I was like, I'm Ivy League educated. It's different now, Dad. He was like, I bet you're gonna show you better than they can tell you. And they showed me that is for sure. That all the rules around the ways in which not only can they police our bodies as patients, but as providers. If you don't act within, if you don't take the red or blue pill, if you don't treat your patients poorly, if you don't agree that there shouldn't be poor people or people of color in these rooms. I mean, that same guy was going to the CEO, telling the CEO, I need you to move her out of this space because her patients are scaring my patients off. And the reason he said that is because healthcare is still deeply segregated. And white folks are not used to sitting in waiting rooms with Black people. Go to a waiting room right now in any healthcare facility, is deeply segregated. We, by law, desegregated hospitals and schools in the 1960s, but the practicality is that they're both very still highly segregated. So our belief of a devaluation of human beings based upon skin color is embedded still in how we practice medicine.
And what were the consequences for you
Oh my God.
trying to disrupt, trying to really make real desegregation?
You know, and the irony is I was just trying to be me. I wasn't trying to fight anybody, honestly. I just was trying to take care of people who I thought everybody should want to take care of. They created an entire committee, reported me to the medical board. Like, it became such a fight simply because I value everyone equally. And I didn't have the language at the time to be able to articulate that. I didn't have the language to be able to articulate what racism is, what it means to say, I ask you for a list of why you should be able to write what quality improvement is. These are the things that you normally write people up around. None of the things you've written me up around meet this list. And what you write me back is, we just think you have poor judgment. You're never going to think I have good judgment. Look at me. You're never going to agree that I have good judgment. I didn't have the wherewithal or the understanding or the framing to be able to give that. I just couldn't understand why we were continuing to have this circular. I didn't understand power. I didn't understand the rules. And so it made me have a whole new career. So they created an advocate out of me when I wasn't even trying to be an advocate. I just wanted to take care of some patients in New Orleans, go to Jazz Fest and relax.
It reminds me of Coretta Scott King, who said, when we started, the bus boycott, we weren't even asking for integration. Right. All we wanted was a more equitable segregation, like there's a black section and a white section. When the white section is full, exactly. You just have to stand. Exactly. But no, y'all wanted to push us back.
Exactly.
And then you wanted to push back on that. Okay, so you created advocates out of all of us, right? Exactly. So how about that?
How about that?
Right. So it's just so in some ways it feels pre-civil rights, intersectionality, pre-critical. I mean, the idea that on such a subjective basis, they thought it was legitimate to build this structure to exclude you, when in the background, they've already said stuff about your patients
exactly
being unwelcome. It's like the sense of being immune or impervious, just not having to abide by any of the racially equitable expectations because you wear a white coat is breathtaking. Yet it's still real. It's
only in the high. So at the time, you kept looking for, where's the power, right? Like, so if doctors are like a bunch of tenured professors, who do you tell on to tenured professors? Like, where does that go? Is there a provost? Like, how does this work? There is really, so to Karen's point, we have no ability to hold really doctors accountable. Litigation lawsuits is nothing. That people are going to pay those off. Like, if we're going to think we're going to get to equity and freedom through lawsuits and malpractice, that's never going to happen. But we have not created any kind of infrastructure for accountability. So that's why we've been working on, and Karen is really a foundation for our work around respectful maternity care, based on theories like Karen's around obstetric racism. Like, how do we hold systems accountable for how they treat Black birthing people? How do we create infrastructure so that when someone knows they're being treated well, there's a way for them to hold the system and the provider accountable? And we're going to have to really do that. And it's similar to in the policing world, where for the last 15 years, they've been doing a lot of training. We do a lot of training, but there's no accountability. So if you train a bunch of implicit bias, you train a bunch of anti-racism, but then people still check it off and go back to their job, we've done nothing, right? We've assumed that the reason they're racist is because they just didn't know. And maybe for some people, but for most people, they just do it because they can. So how are we going to hold that system accountable? Because they can't, they should not be able to.
And this is also why there's so much pushback on some of the conceptualizations and tools of accountability, right? Because if training is not enough, the way that you show it's not enough is that you actually show how the outcomes are a product of implicit biases, structured inequalities, intersectional barriers. So the pushback now across the country in many states is, well, okay, you can't talk about that stuff. Even the CDC in the middle of this huge pandemic where bodies are dropping left and right, there was actually an effort to say, but you know what, we can't talk about structural racism.
And I thought about you, honestly, about when they were trying to get rid of taking intersectionality out of the courses, and thinking about my own experience of being a medical student, 23 years old, and them saying Mongoloid, Caucasoid, Negroid. The reason they want not to say your language. They don't want somebody to teach intersectionality. They don't want somebody to talk about racism. They want to keep being able to say Mongoloid, Caucasoid, Negroid, right? So when we bring in actual facts, then they say, oh, we're making up stuff. No, actually, that was made up. That was never a fact.
Made up of the status quo. And you know, as we're talking about that, and I want to hear the work everybody is doing. We've heard a little bit of it from Gail. But one of the other things that gets made up that's part of this is that the disparities are a product of race as a variable. And Alisha, I want to come to you about this because you have a sense about why saying race but not racism is part of the problem. So help us understand what's happening when they say race is a variable, but they're not saying racism.
Yeah, it's very curious because, you know, when I was a medical student and even as a resident, when you're reading kind of all of this academic scholarship around health conditions, they don't really say much about patient populations, but there's always, you know, age, there's always race. Even if there's just one or two things that you know about patients, you always know their age and their race. But then the curious piece is that there isn't ever an explanation as to how you can interpret explaining somebody's race or displaying that really means. Oftentimes there's this assumption, because there's no explanation around the social determinants of health and around structural racism and how, you know, race is really a proxy for that there's this assumption that there's some sort of behavioral flaw in these individuals, that in most of these studies, it's usually people of color who end up with these disparate outcomes. So in the minds of the readers who are trying to interpret this information, it really appears as though it's an issue with the patients themselves, right? There's never this speak about, well, it's really these structural issues that are causing that. And what are these structural issues? That's never explained. You know, even now we hear a lot of buzzwords around structural racism, but in many cases, that's never really pontificated upon. We know that structural racism really means that there's, you know, issues with how resources are allocated and how they're distributed among populations, where individuals who are white usually are the individuals who are the benefactors of that, how there's laws and policies in place that really favor and prop up white supremacy in all of our societal systems. But that's not really ever explicitly said, right? And the reason why I say that is because when I went to my doctor and she told me that I had gestational diabetes, I was so flabbergasted, you know, because I'm like, I'm so healthy. I exercise, I eat right. I've done everything I'm supposed to do to stay healthy. I might be a little bit older, you know, as a pregnant woman. And she's like, well, it's because, you know, you're African-American. That's basically what she told me. And I'm like, well, what does that mean? Like, does it mean I'm, and she couldn't really say, she couldn't really explain that, right? So that's really, you know, the nuance I think that's missing from the argument when we say, oh, it's because this person's Black that they have this issue. Even now I have several friends that are pregnant. They're all of advanced maternal age, which, you know, that term, I'm like, oh, really? Are we advanced maternal age? But now all of a sudden there's this trend where all of my friends who are Black women are taking aspirin. And I'm like, oh, did you have, many of them are first-time moms. Many of them are completely healthy, no prior medical issues. And when I asked them, well, what did your doctor tell you was the reason that you needed to take aspirin during your pregnancy? Oh, it's because I'm Black. Okay, well, did they explain to you like what specifically, apart from just having like brown skin, was your risk factor? No. So this is a major issue, I think, in medicine that we really need to be explicit in our medical research, also in our scholarship about why we use race and what it's a proxy for, and being explicit about racism as being the cause for these disparities.
Yeah. You know, it's such a marker of what happens when racism is taken off the table. You know, the racism is the process. It is more of a, you know, race is more of a verb than a noun. But when they take off the table or never open themselves to a conversation about the processes of racism, what we get is this static categorization, of race as the factor, as the variable, and that in turn places the difference in our body, right? It's in our body, and we are the site of the intervention, rather than the institution itself being a site of the intervention. So they get the credit for, well, we're trying to shape the intervention, trying to be race sensitive. But in doing so, they're actually perpetuating the denial of the function of racism that contributes to these outcomes. Now, what I'm curious about is what goes on in med school. What should be, I guess, part of medical education that helps make this shift from the idea of race as a variable to racism as an environmental context in which health is determined? Because from what I'm hearing, from what you all are telling me, this is not really what you're going to see in med schools or on faculties or even in institutions. So Karen, what's your sense about where do we build out from the observations that you all have been making about the limitations and what they produce?
Yeah, I mean, like, where do you begin? Like, we could start, right? We know about redlining, we know, and I've written about philanthropic redlining, and let's talk about epistemic redlining. Like, that is what medical school has done. It has excluded experts like Dr. Wyatt, Dr. Crenshaw, from even being a requirement or a prerequisite to get into medical school. You push all the, whatever that means, natural sciences. So people, they discard humanities for caring for human beings to prioritize all the things that reinforce that race is a biological construct, or that Black and brown people are structurally racialized, minoritized, marginalized people. Something is innately deficient with us because of either our skin color or our genitals or our body size, right? And so we reinforce what, earlier Dr. Joia Crear-Perry was saying, like, medical school really is just a reinforcement of white patriarchal supremacy, like, period. And even if we introduce critical race theory, intersectionality, reproductive justice, the folks, the actual experts, are not even being invited to actually teach the very discourses and scholarships and concepts that they created. It's being co-opted by academic institutions who want to, right, use rhetoric to lure Black and brown or people who are from minoritized populations into the field. And so we would have to really dismantle it and start all over, because we haven't prioritized legal studies, social sciences, humanities. We still have this, right, hierarchy of healthcare where the physician, right, knows all things, but sometimes it's not really there, depending on what setting it is. We haven't really thought about the fact that we are a team, and that team includes different people from different walks of life, different types of formal and informal training. And we actually don't even include the very patient in the design and evaluation of the healthcare that they're being paid, being made to pay for, whether it be through cash or public aid or employer-based insurance. Like, we've excluded the most important people in the actual care that they're seeking for something that's going on in their life. It's really dehumanizing. I mean, I know for me, sitting through medical school, I was tired of going to, and even though I love my medical school, I realized that I was gonna die from most things except for the genetic things, like all the lifestyle things. And so we teach this current generation and past generations that it is your individual behavior that is the ultimate determinant of your health. And we know that is not true. Every other discourse, right, and discipline knows that. But medicine, we have been very forceful in our denial of, right, of what social ecological models of human rights, of social justice, like we demonize and discipline people for speaking out and speaking up and wanting to bring ethics and integrity and a sense of accountability and you know, opening up the table, having more chairs at the table, redesigning a new room, like making a gate open for more people, more representation, more shared power decision-making. We don't really do that. I mean, we really actually disincentivize people from providing humane care. In so many ways that people are choosing, right? Again, their career advancement over our humanity, over our care. And it's really difficult to see that, especially when the systems pit us, right? Black and brown folks against each other, academic versus community, or, you know, advocacy versus policy in this institute, like all the different labels that we use, again, to differentiate when we all are doing similar things for that outcome of, right, again, life and liberty, like thriving and not just surviving. We would have to have a new rehaul of the entire medical education system.
Yeah, I wonder what abolitionism would look like in health.
Right.
So, and Gail, so you are an exception in that you do have, you teach, you have access to medical students, you bring much of this knowledge that so many other medical students don't have. In terms of some of the things that we have talked about, there are two things that I just want your quick response to. One is, part of, we talked a little bit about plantation ways of framing Black women and using Black women having survivals today, right, in gynecology and the way they treat us. But another part of what happened during the plantation system and the breeding of Black women was the development of stereotypes about our sexuality, about who we are, about how we do what we do, that are also in some ways uninterrupted, right? So it's not just you can drop it in the field and keep working. We don't need to teach you nothing. We treat you like livestock. There's also the way our sexuality has been constructed through that moment in history. And that just really hasn't been taken up within the culture very much at all, which I think, as your work suggests, creates emotional consequences for Black women. So the
and health consequences.
We don't talk about that. And we don't talk about mental health for Black women writ large. You know, say her name, many of the Black women who have been killed by the police were suffering from mental health challenges, yet they were seen through this same sort of stereotype of the banshee, the out of control person who has to be put down. So I know that's a big pot there to stir, but you're the only person that I know consistently who has stirred that pot. So I'm putting that pot in front of you now.
Well, I'm so happy to have the opportunity to talk about it. This is such a great group of people to really start thinking and stimulating other ideas about what should be done. But I do have some hope, Karen, from what you're describing, that's so much missing in medical education. It is coming. And I think at UCLA, to toot our horn, we are revamping the medical education system. And let me tell you, it didn't come from faculty. It came from the students. The students come to medical school now, having known enough to know they don't know. And they figure if they don't know and they leave after 4 years or 6 years of residency, whatever, and still don't know, shame on them. And so they are demanding that they learn. And I think it's a wonderful opportunity to be in medical education today, because finally I get an opportunity to place the work that I've been doing for the last 48 years right in that perspective. And I can go back when Kim talks about how women have been treated and the assumptions made. One of the assumptions is that girls who are reaching puberty have already had sex. You know, because we are just a sexual group of people, we have no morals and we don't experience pain, that all legitimize rape. And people don't realize that has absolutely no scientific basis. When I first started out in the 1980, I got my first NIH grant and a K award to go along with it to study African-American sexuality. And a lot of people don't know that because they had to change the names of my research projects in order to get them funded. because Ronald Reagan was the president at the time. So I have survived 7 presidents and I'm self-funded. But that's another story. Let me go back to the way that young teens, Black teens were treated. If they were pregnant, it was assumed that they were pregnant because they were promiscuous, that there was nothing that they wouldn't do. And when they went to the gynecologist, I have some really heartbreaking stories of young women who went in to a gynecology examination and asked by the doctor, has anyone ever looked at you with these devices that I have in front of you, and looked at your vagina and all of the things that follow it? And they'd say no, but the gynecologist would use an adult speculum on them, which is extremely painful because it stretches beyond the scope of what a little girl who hasn't had sex at all should have to encounter. So she would have to yell out and cry, but I haven't had sex. And this has been a drumbeat that Black women have had to fight against for decades, that when a young girl becomes pregnant, when she becomes promiscuous, it isn't because she was born that way. It is because of the experiences that have been forced on her, or she's been overexposed by people in her environment who are too sexualized, or on television, watching a very recent program where Black women dressed like hoes and wrapped themselves around a pole and pretended like that was entertainment. That's not entertainment, that's confirmation of a stereotype that's older than any of us all added up together. Shame on them for thinking that they need to perpetuate the fact that we have no morals when it comes to our body. We don't need to do that ourselves. And yet we have drunk that like Kool-Aid. There's so many young girls today that don't realize that you don't have to have sex because all your friends are talking about it. We can't even have sex education in the public school system without getting the Board of Education to approve of that experience, that knowledge. And without it, our girls in the public system learn very little or nothing until they get to middle school, which is 13, 14. They ought to be learning this 8 to 10 years old. That's the premium time to learn it. Learning about the body parts, learning what they do, learning what a woman needs to know and what she needs to say and how she needs to protect and honor herself. That is a castle for her. And we have to socialize our girls and demand it, because it doesn't come in this society without it. But
you know, I can't help but think as you're talking, Gail, about Dr. Jocelyn Elder, who still is kicking and putting it out there, who got fired for advocating a sex education, masturbation. So that can't be done, right? That can't be done. Yet all sorts of other things, can be done. Your work actually was very helpful in raising, the fact that people do read cultural representations onto their own bodies. And if their own bodies don't respond in the way the cultural representation says it does, they think there's something wrong with them. So, and I just, want to encourage people to read Dr. Wyatt's work, and I know there are going to be some, and there's a whole debate about autonomy and sexual representation. So I don't want people to think that we're not aware of that. But there's also a reality that people should also be aware of, that these representations do give people self images that sometimes don't map onto their own sexuality, and there's nothing wrong with them because they don't want to jump up there. And
and what I'm saying is, if we had a range of images, Kim, where we saw women who were very free with their bodies and relaxed and felt that this was their right and this was part of being a woman, that's great. But we also need other messages, and there are other ways to express sexuality other than wearing absolutely nothing. And there's ways that you don't even have to show anybody your body at all, and that you should make decisions about the sexual partners you have and when you're ready to have that kind of experience. That we don't need to show one image of a Black woman. And there's nothing wrong with her. She doesn't have a mental health problem because of it. That's what I'm saying. If we get the same image and Black women keep perpetuating that same image, then we are a part of the problem, not a part of the solution of showing the ranges of women that also have other stories and other ways to celebrate their sexuality.
So speaking of solutions, in our last couple of minutes, I want to direct our listeners to some of the projects that all of you have been pursuing to address the issues that we've been talking about. So Joia, I know you have a big project in this hopefully new administration. So could you give people a quick sense of what it is and where they can get more information and support the project?
Yes, thank you, Kim. So back in the spring, when everybody was writing what they wanted a new administration to do or a new candidate to do, the National Birth Equity Collaborative, which I lead, wrote a birth equity agenda. And our first ask was to open a White House office of sexual and reproductive health and well-being. We really believe that the space to undo the harm and the belief that we must plan better, the eugenics, this idea that it's personal responsibility, that all of that starts at the highest level of government, because that's where that belief was created and caused harm to our communities. In fact, if President Nixon had not used his anti-poverty strategy, was family planning, where he put family planning clinics across the United States in Black and brown communities, as if not having children was the way to get to justice and joy. We know that if he had in 1970 said our anti-poverty strategy was free college, that we probably would have less poverty in the Black and brown communities. So we have an opportunity to use the power of the White House to work on both domestic and global policy to undo the harm and the blaming and shaming that we do of Black and brown bodies, especially Black and brown women, really tying and undoing the harms that we've done for generations. So I'm excited about that. We have about 150 organizations who've signed on, a Senate letter that was led by Senator Gillibrand, Senator Warren, and Senator Booker, and a House side letter that was led by Congresswoman Lee and Congresswoman Kelly. We are hopeful that it will be in either the White House Domestic Policy Council or within the Vice President's office. It would be a great opportunity for the Vice President to lean in and to build out sexual and reproductive health and well-being. Our organs are not just for producing babies, we use them for sex and for pleasure. And so that's why it's both reproductive and sexual health and well-being. And how do we undo these harms and build a better nation and world?
And let's also remind folks that you will be hosting a maternal health week.
Yes.
Beginning April 11th. So people should check that out. We'll provide links to that. So, when you get done with this, just take
come on over to Black Mama Better Alliance has Black Maternal Health Week. And come on and we'll send you some links. Thank you very much.
Yes. And Karen, you're working on a measurement. So tell folks what you're up to.
Yes, so we actually, we developed this measure last year, and we actually are validating the instrument, meaning not the experiences of Black women, but what we have done is developed a soon to be validated patient-reported experience measure of obstetric racism, also known as the PREM OB scale. And it is a new tool that for the first time will be able to translate the explanatory framework of obstetric racism, which sits at the intersections of medical racism and obstetric violence, defined by Dr. Donahue Davis, who's a Black women's anthropologist and doula. With her permission, I translated that framework into domains, patient-identified quality of care domains in 7 areas. And these areas have all been named, defined, and measured through Black women's lived experiences, their words, their perspectives. And they came up with these things through our focus groups in 2019. And then in 2020, we released this survey during a pandemic. So 815 Black mothers and birthing people from across 34 states in DC and 348 hospitals in the United States shared their experiences of seeking help in healthcare in a hospital for labor, birth, and postpartum in these areas called safety and accountability, social capital and kinship, autonomy, communication, information exchange, racism, empathy and humanity, and dignity and Blackness, and holistic care. And just, the goal ultimately is now we can quantify what we've always known, and provide a quality improvement tool to hospitals, health plans, community partners, policymakers, to actually now examine the associations of these adverse outcomes in relationship to the experience and impact of care through the words and perspectives and feelings of Black mothers and birthing people. And my ultimate goal is to really hold, like what Dr. Crear-Perry said earlier, systems accountability. So now we're inviting health plans to tie value and reimbursement to Black women's reported experiences of care through this framework of obstetric racism, and to stop denying what we've been saying in other disciplines, and now be able to bring social sciences, humanities, public health, all of that into the QI, quality improvement space, and shift the care, shift the measure, and hopefully have a different experience for Black mothers and birthing people.
One of the things we know is that if it's not measured, it doesn't count. If it's
Exactly.
it counts, it gets measured. So you're building up from making it count by developing the measurement. So people should look for more information and be prepared for the information to actually shift our conversations. Alisha, I know you're holding it down and keeping it strong for all the Black women that sort of find their way to your practice. What do you want to leave our listeners with?
Yes, absolutely. So I currently founded an organization called Empower Her Health, which really focuses on empowering Black women in particular to have healthy pregnancies, and also promoting healthy infants as well. Part of what I do is a lot of reproductive health education. A lot of it's centered around reproductive justice and providing information about health in that lens of racism and in terms of justice as well. So one of the things that I'm working on now, because, you know, really centering Black women's stories is very important to me, is a storytelling campaign where I'm really trying to collect stories from women of color about a range of reproductive health issues, so that we as a community can start to recognize when there's experiences that we have that aren't good, that are really seated in racism or injustice or dehumanization, and being able to call that out, being able to say that, to be able to activate ourselves and become advocates in our own community and for our own care. So that's kind of what we're working on now.
Wonderful, wonderful. And how can people find information about it?
Yes, absolutely. People can certainly find us on Instagram, Happy Healthy Dr. Alisha, and also at empowerherhealth.com.
Okay, wonderful. And Gail, so we know that people can find your book. What else do you want to direct those listeners who want to learn more, know more, be more of an effective advocate for Black women's well-being?
Well, they can go to the website and look for the Center for Culture, Trauma, and Mental Health Disparities. That's our center at UCLA. It's 16 years old, funded by NIH, and I'm very proud of it because there are not many centers that do research on women's sexuality led by a Black woman. It will contain all kinds of documentation that I've shared with you today, over 250 research articles, both internationally in South Africa, where we have training programs, as well as here in the United States. And just lots of opportunities to read on what we're doing, volunteering, if they're students, but there are just lots of opportunities in this particular area. But most importantly, Kim, we're all creating an image of a Black woman taking care of her business, research-wise, clinically, as personal moms, advocates, just presenters, lecturers, university professors, and those are images we just don't see enough of. So I'm so thrilled to have this opportunity to be on this panel with all of you. And I hope we have an opportunity to make our constituents grow by then looking up what we're doing and carrying forward.
Taking care of our business. I think that's going to be the subtitle of this conversation, because you you all sure helped us do just that. I can't really thank all of you enough for your candor, your honesty, your thoughtfulness, and for the essential work that you all do. So to kick off our entire week with an event like this just shows how powerful and important gathering around the intersectional dimensions of our lives can be in understanding and responding to the crises facing Black women. So thank you all so much for joining us. And I also want to thank my team at the African American Policy Forum and the Center for Intersectionality and Social Policy Studies. Couldn't do it at all without them. And also to shout out and thank Dr. Joia and the National Birth Equity Collaborative for partnering with us on this event. So go out and sign up for their next event. Follow Dr. Karen Scott's work. And make sure that you build on the conversation and the knowledge that was just so free-flowing in this conversation. So our week continues tomorrow with a conversation entitled Engendering the Politics of the Black Athlete. So we can't wait to talk about that. It will feature ladies.
Come back for that one, Misogynoir. No.
Come on. Sydney Colson and Demario Davis, football player, great for New Orleans. And we'll be exploring the athlete activism in the new era that finally begins to center Black women. We'll also have a real special surprise guest. You will have heard of this guest, but I can't tell you who it is. So you just need to log on tomorrow and join our conversation. Now, then Wednesday through Friday, we're going to have a mini film festival, and we're going to watch, engage, and discuss 3 critically acclaimed films that feature Black women. Coded Bias, that deals with the racism in artificial intelligence. A Love Song for Latasha, a short film about Latasha Harlan. Some of you will know that Latasha was a young teenage girl who was shot in the head in a convenience store by a Korean shopkeeper, a woman who ended up getting a $500 fine and no jail time. It was one of the unknown factors that led to the uprisings that many people think was just about Rodney King. So please tune in to that and join us for the after conversation. And finally, on Friday, Still I Rise. It's a powerful documentary that examines the relationship between racism and sex trafficking in the Bay Area with a particular focus on girls. So you can get a lot of information about this week's programming by visiting aapf.org/HDD and following our social media channels on Twitter, Instagram, it's AA Policy Forum, and me, Sandy Locks on Twitter and Kimberlé Crenshaw on Instagram. So if you've been inspired by this conversation and want to partner with us to sustain these conversations in difficult times, do consider donating to AAPF at aapf.org/donate. And you can write us at info@aapf.org to find out other ways you can get involved. Thank you for joining us today. We hope you stay with us throughout the week as we continue to uplift the stories and the status of Black women.